Dr. Pallavi Mishra, Dr. Sinha, and all of you for this fabulous scientific treat that you have planned. I can see there are various sessions right from basic science to clinically relevant uh, sessions also. So it's been quite a treat. Without further ado, I want to shake you off your Sunday slumber. Every time we talk about something new, something that threatens to replace something that has been established and is standard practice, we all are a bit shaken. So I hope I can stir a lot of thoughts in your mind about this and about this new concept of TIR, or time in range, which is coming up very fast as a new metric in preventing complications in diabetes. We all can agree that that's probably the main reason why we treat diabetes, because we want to prevent complications. And this is a new metric that promises to do so and help us in doing so. So my talk is divided as, era of HbA1c and its limitations, and then the novel metric introducing time and range, and then some of the guidelines that are available on time and range and its use. So HbA1c era, and it still rules the roost. So we as physicians know it's the gold standard. We diagnose diabetes based on HbA1c. We use it as a standard marker to assess the risk of complications, and it's a standard target that's given in diabetes algorithms also when we want to stratify patients or talk about different drug regimens, etc. From the patient's perspective, again, it is very important because it becomes the main glycemic metric for guiding therapeutic changes, right? And the main metric for rating the quality of diabetes care and medications that the patient is receiving. Now, when we look at it from the regulator's perspective, we know that it's an important outcome marker for health authorities in evaluating new medications and technologies and looking at their impact on this marker as and approving those newer technologies and newer medications. So overall, it's the golden standard in diabetes and has been established and well used for so many decades. Now, again, this is a landmark trial, and this graph is absolutely no surprise to any of you in this August audience. You all have seen this DCCT trial in type 1 diabetics and this beautiful association between different gradations of HbA1c and the occurrence of microvascular complications, namely retinopathy, nephropathy, neuropathy, microalbuminuria, depicted by the different colored graphs. So you can see that with each increase in HbA1c, we could see that the rate and risk of the relative risk of each of these complications increased. And this established HbA1c as a marker for tracking these complications. But of course, something that is so well used and standardized today is also, it comes with its own limitations and has some disadvantages. And let me quickly review that for you. So first of all, it does not capture hypoglycemia. We know it comes as a single value and expressed in percentage or another unit, but it does not really tell us if there is, it can point out sometimes, but it does not really indicate or capture hypoglycemic event per se. It does not also capture individual differences in HbA1c, and by that I mean there are varying patterns of glycemic control with identical HbA1c levels and similar mean glucose concentrations as well. And certain conditions like hemoglobinopathies or iron deficiency anemia or even pregnancy can confound the measurement of HbA1c, thus limiting its use. And finally, and importantly, it does not capture glycemic variability. Glycemic variability is nothing but the swings in blood glucose, the troughs and peaks, or just the highs and lows in very simple language. So HbA1c does not tell us anything about how much the blood glucose levels have been variable. And several studies have shown that glycemic variability, again, is a very important marker because with increased risk of hypoglycemia, cardiovascular outcomes and all-cause mortality can also increase, and there is a strong association with glycemic variability. So these are some of the important limitations with HbA1c, and let's see how, and I want to just demonstrate how, what I mean by, at the same HbA1c level, someone can have stark different glycemic profiles. So here the top portion or the top graph belongs to patient 1 with an HbA1c of 8, and the lower graph belongs to patient 2 with an HbA1c of 8 as well. And from graphically itself, without even looking at the numbers, you can tell that the lower graph has less fluctuation, as in the peaks and troughs are not so many and they are not so wide. But the top one, definitely there are lots of peaks marked by high glycemic and lots of troughs as well. So clearly showing that the fluctuation in the glucose values per day are very high in the top graph. But mind you, these two patients are at the same level of HbA1c, and this is a stark example from any of our clinics, for example, and this is what we see in clinical practice. So high glucose variability with episodes of hypoglycemia as well as hyperglycemia are quite obvious in patient 1, whereas patient 2 is slightly more stable and has less glucose variability. So this is what I mean when I say glycemic variability. It has also been seen, and here is where they've seen the fluctuations in fasting levels of glucose. And the light blue ones indicate the low variability fasting glucose levels. The dark blue are the medium variability, and the gray are the high variability fasting glucose values. And you can see that each of these complications, say for example, severe hypoglycemia, MACE, and all-cause mortality, all seem to be the highest in the group with high variability of fasting plasma glucose levels. So again, fasting glycemic variability is also correlated with adverse outcomes, and this needs to be noted well. In most patients, as motivated as they might be, and as many times as they might do, monitoring of blood glucose at home, we know that most patients with MDI or on MDI therapy may probably do it 3 or 4 times or 5 times or 7 times a day as well. And these are the typical readings we receive, right? As soon as they wake up, and then at pre-lunch, and then pre-dinner, and probably at bedtime. So this is what we expect, and these are the 4 time points we see. If we see that the glucose values are well within the range, we are not that concerned, and we are under that impression that this patient is under good glycemic control. But look at this graph for the same patient, where I connect the dots between those 4 time points that the patient measured, and clearly you can see that how the glucose fluctuates between these time points is a different story completely. You can see the peaks and the troughs, or the hyperglycemic peaks and the hypoglycemic troughs marked in red here. And you can see that except for those 4 time points that the patient showed us, the rest of the day, the sugars are varying quite a bit. So this is the importance of glycemic variability, and such a phenomena can come to light only when we do a continuous glucose monitoring, typically the flash glucose monitor that we use in patients, and get the data to look at the glycemic variability and other matrices. So the world is changing. We already established the importance of HbA1c. We looked at how well it's correlated with complications in both type 1 and type 2 diabetes patients from the UKPDS study. And we also realized from that study that every degree reduction in HbA1c and closer to control or target HbA1c is associated with a massive or substantial improvement in the risk of complications associated with diabetes. So the world is evolving. We have HbA1c, we are stuck to it, but we are also moving fast and making strides towards TIR, or time in range, right? And with that, the ATTD, or the Advanced Technologies and Treatment for Diabetes group, met in Berlin in 2019 and published the international consensus on TIR, and I'm going to walk you through that. Well, technology is only for those who can afford and only for those who are willing. So different countries will naturally move at a different rate, but I am happy to say that I think India has, even despite the wide extremes in our population, things have been going quite well for most of us in that sense, because there is more and more uptake of technologies. And let's remember that the more we use, the better we will, companies will be able to make it affordable for our patients, and we can leverage on the advantage provided by the technology advances. So in short, the glycemic triad, which included HbA1c, fasting, and postprandial glucose values, has now very beautifully evolved into a glycemic hexad, including other important parameters like nocturnal hypoglycemia, hypoglycemia itself, and importantly, glycemic variability also. And I think I discussed in detail as to what happens when we have those fluctuations in the glucose. So with that, I want to introduce you to time in range. Time in range is nothing but just the time spent in the individual's target glucose range, which is usually between 70 and 180 milligrams per DL, but occasionally it may be changed to say 70 to 140 or 70 to 120 milligrams per DL. Percentage of time spent below, which is TBR, or above, which is time above range, or TAR, indicates either hypoglycemia or hyperglycemia respectively, right? Time below range is hypoglycemia, and TAR, or time above range, is hyperglycemia. It may be used as an appropriate endpoint in clinical research trials and as a measure of glycemic control in patients with diabetes. And there is definitely emerging and evolving evidence that supports TIR is conversely or inversely related with the risk of developing microvascular and macrovascular complications in patients with diabetes. So it's getting more and more validated. Time in range, and this again beautifully describes what we are discussing in a graphical manner. If you focus on the central column, you can see that the green area marked from 70 to 180 is the target range, right? 70 to 54 milligrams per DL is 69 to 54 milligrams per DL is the low range. And then anything below that is the very low range, less than 54 milligrams per DL. Similarly, above 180 milligrams per DL is the high range, and above 250 milligrams is the very high range. And we label these appropriately as time in range, 70 to 80. And then level 1 hyperglycemia up to 250, and then above that is level 2 hyperglycemia. Similarly, 69 to 54 is level 1 hypoglycemia, and below 54 is level 2 hypoglycemia. And in terms of percentage, it's known that people with diabetes should spend at least 17 hours a day, more than 70% of their time within the blood glucose range defined for them, usually 70 to 180 milligrams per DL. Similarly, the hours have been calculated for the remaining TAR as well as TBR as well. So now, if we, and there are consensus reports and the international consensus on use of CGM also, and a variety of associations coming together and investigating metrics for type 1 diabetes patients, and then endorsing that TIR is a good new metric to use to understand what's happening in these patients. So if we have to overall look at both of them and compare them, of course, HbA1c is nowhere to go. It's still a very absolute standard that we are using in practice, but it has limitations. So HbA1c evaluates a single HbA1c value, whereas TIR evaluates continuous glucose level. HbA1c will compare the every 3 months, and then this is a comparison of any time period. We know HbA1c does not capture hypoglycemia that well, and also hyperglycemic levels occurring in the same particular day. The overall level can indicate average sugars only. TIR, on the other hand, captures everything beautifully, and HbA1c does not reflect immediate treatment changes or lifestyle changes as well. So it's not a very good correlation to patient-reported outcomes. And there may be some interference in certain conditions, which I've already discussed. But overall, a good correlation to clinical endpoints, including and has many long-term studies that have been already done. TIR, on the other hand, has good correlation to patient-related outcomes and low susceptibility to interference, but at the same time, it's not all that well studied or standardized as yet. Now, like fasting plasma glucose or average sugars and HbA1c all have a correlation or associations, we can see that there is a correlation between HbA1c and TIR as well. And this has been studied across almost 18 studies across different age groups in both type 1 and type 2 diabetes patients. And a good correlation has been calculated using mathematical models. And for every absolute 10% change in percentage of time in range, there's almost a 0.8 to 0.9% reduction in HbA1c. So you can see that, for example, 50% time in range would probably correspond to an 8.3 percent HbA1c. Similarly, now coming to an important aspect, the hazard rate of development of retinopathy progression was noted or was increased by almost 64%, and development of microalbuminuria that's seen on the right was increased by 40% for each decile point lower TIR, which means that for every, there was a good correlation between time in range and microvascular complications like retinopathy as well as microalbuminuria. In fact, a study has also reported this association between TIR and neuropathy also. And there is an increase in the progression of these complications when there is a decrease in TIR. Similarly, this was again computed using computer models. The IQVIA core diabetes model was used to was fed with all the HbA1c values, and conversions were created. And here they looked at the cumulative incidence of developing major diabetes-related complications over a 10-year time period in both type 1 and type 2 diabetes patients. And you can see clearly that complications like myocardial infarction, end-stage renal disease, vision loss or amputation it's definitely improved when time in range is either 70 or 80%, as compared to 58% in both type 1 as well as type 2 diabetes patients. So now coming to what do the guidelines say about time in range? We know guidelines and consensus often they are often created or always almost created with a panel of experts reviewing all the available data or evidence with respect to that particular medical or science question, and then they come up with their own set of guidance or recommendations for the rest of us to follow. So the international consensus report on CGM, which is continuous glucose monitoring, and time in range, this provided guidelines and recommendations for clinicians, researchers to use, interpret, and make decisions based on the CGM data for effective diabetes management. And these supplements previously agreed upon CGM metrics. So the first such recommendation by an expert panel came in 2012 on the standardization of CGM metrics. There's no point in every company coming up with their own metrics or every country doing something different, because then we are not able to compare data or learn from our experiences. So standardization of CGM metrics was the number one goal for this expert panel, and they came out with their recommendation for that. That has further been updated, and several publications now have found place in our scientific journals on CGM metrics and CGM data evaluation, but no formal adoption by any professional organization. So these were a group of interested experts with experience in using this technology, but no association had adopted this as such. But as of now, since 2019, the international consensus at the ATTD in Berlin, Germany was convened, and they developed CGM targets based on the currently agreed upon CGM metrics. So that was the first important step that was taken. We Indians are not lagging behind. This wonderful paper by Dr. Unnikrishnan, Dr. Banshi Sabu, Dr. Joshi, Dr. Jyoti Dev, Dr. Manoj Chawla, Dr. Neeta Deshpande, Dr. Rajiv Chawla, and the illuminating panel of experts here have also come with the consensus statement on the use of ambulatory glucose profile in patients with type 2 diabetes receiving oral anti-diabetic agents. So they defined, or they attempted to define the role of AGP in our patients on OADs, and they also reviewed the various aspects of AGP and its interpretation. And this is available based on the available evidence that we had so far for disease management using AGP. So this article aimed at discussing the consensus of the expert group on the role of this technology and its interpretation, and definitely giving suggestions on how to improve the treatment of our patients. Recent guideline updates towards standardization of CGM metrics and reporting has also occurred. And again, 10 CGM metrics for clinical care have been defined with specific guidance on targets for TIR, which is time in range, TBR, time below range, TAR for adults with type 1, type 2 diabetes, and special populations, including older or high-risk populations, and also pregnant women. Standardized ambulatory glucose profile as a template for data presentation and visualization has also been recommended here. So what happened is every company or every sensor device was coming up with their own metrics, which was not making sense for all those in question to use. So when an independent group, Dr. Madze and all from Minnesota, came up and they developed this ambulatory glucose profile, it was endorsed by ATTD as something that should be taken up by all, and attempts by all companies making sensors should be made to integrate their technology with the AGP format. So that standardized AGP profile is available for all of us to understand and interpret and then make sense of that data. So what does the international consensus for CGM data interpretation say? Again, this is that these are the different columns or different recommendations for the different populations, as you can see. The leftmost is for type 1 and type 2 diabetes patients. The next one is type 1 and type 2, but older and high-risk patients. The third column or third set is for pregnant type 1 diabetes patients. And the next is pregnancy, GDM, and type 2 diabetes patients. So the green bar represents the target range. It's been well defined in these different sets of populations, 70 to 180 mostly, except in pregnancy where it is 63 to 140 milligrams per deciliter. Now, the recommendation clearly shows that the width of these, the length of these bars is different, which means that the time spent in range is recommended differently for the different populations. For example, for the type 1 and type 2 diabetes patients, more than 70% of the time, which is equivalent to 16 hours in 16 hours and 48 minutes for 24 hours is what is recommended that the patient should be spending to get to that good A1C control. Similarly, these are level 1 and level 2 hyperglycemic ranges defined here. For example, the older and high risk patients can spend just about 50% or more than that in the range, and less than 50% in the or less than 60% in the hyperglycemic range, and definitely less than 1% in the hypoglycemic range. So this is the recommendation given for the different populations. Of course, it's still evolving and it's not completely final and out there, especially for populations like pregnancy and GDM. But overall, it has been studied and well established that every incremental 5% increase in time and range is associated with clinical improvement for both type 1 and type 2 diabetes patients, as you can imagine. These have been adopted also by the ADA and EASD gradually, and they are defining time and range in their guidances as well. Similarly, ACE has also taken it up, and lifestyle therapy and ongoing glucose monitoring with CGM has been recommended in their guidance as well. So recommendations to achieve TIR, we know that type 1 and type 2 diabetes patients achieve the goals for both TBR and TIR. First priority is to reduce time below range or hypoglycemia to target levels, and thereafter address time in range and PAR targets. As far as older individuals are concerned, we definitely want to customize our approach with a strong focus on reducing time below range or hypoglycemia, and of course, reducing excessive time above range. As far as pregnancy in type 1 diabetes, that's been well studied, and we know that we want to safely increase time in range at an earlier stage of gestation so that the pregnancy outcomes are good for both maternal and fetal health. Pregnancy and gestational and type 2 diabetes, that needs more data to define. So far, there is no recommendation as such to use it, but we know empirically that using it is probably better and faster to achieve good glycemic control in these situations. So in summary, HbA1c is the gold standard for diabetes management, but it does not demonstrate a holistic and individualized glucose profile. Importantly, does not tell us the glycemic variability. TIR or time in range provides a much closer look on the person's glycemic status and helps us understand glycemic variability completely. Increasing time and range is associated with reduction in the microvascular and macrovascular complications in people with diabetes. And international guidelines have now been updated to include consensus on CGM data interpretation. Thus, there is an evolving need or evolving path towards TIR from HbA1c, and we need to optimize that for perfect diabetes management. I just want to quickly draw your attention to this clinical case. A 56-year-old female patient visited me in January after almost a year because of the lockdown and a pandemic ongoing. Known case of type 2 diabetes since the past 4 years, BMI at 28 kilograms per meter square, and she came with an HbA1c of 8.5. She was in a standard combination of DPP-4 inhibitor and metformin, had hardly checked her sugars through the last year, but was not able to adhere to any of the lifestyle changes given. No other history of complications. So my hunch was, obviously, we spent a lot of time talking about how her lifestyle had changed in the last year, but also I wanted to escalate her doses and not without a thorough discussion with her. And she said, "Doctor, please give me some time. Let me get back to my diet and exercise, and I'll show you the difference." And on the left is the first, we also discussed about doing a continuous glucose monitoring to understand her current lifestyle and then what needs to be done. And we put the sensor on her, and the first 7 days on the left, you can see that There are lots of hyperglycemic peaks because of the non-adherence to dietary changes. And the same have gradually improved in the next 7 days because we called her for a follow-up visit. We recounseled her and gave her a new diet and motivated her further to, start walking and stuff. And you can see the improvement here on the right. So this is an acute and a beautiful change, and it's a great tool and a great informative technological use for the patient as well as the healthcare provider. So with that, I'm thankful. I have 3 abstracts at ATTD which have been selected, and I'm thankful to my collaborators. We have one which I can't disclose much about because it's still under the conference embargo, on time in range, where we are talking about continuous glucose monitoring and what we have seen, our experience in the patients. And I'm thankful for the collaboration with Dr. Purvi Chawla, Dr. Banshi Sabu, and Dr. Jyoti Dev. With that, I thank you all for this great opportunity and patient hearing.